Hi, this is Oscar Mendes again. A little bit noisy in this room because we are open the box for the bar. Sorry for that noise. Here I will introduce this other team in the lab number 4 at Paolo Foundation University Hospital. Once again, it's an honor for us being shared this initiative with such important colleagues doing cases. I was watching the cases since last night. I slept very few hours because I was watching the cases and were really terrific. On my right side is Dr. Carlos Fava. Uy, me agarró la laguna. Well, Dr. Joaquin and technician, nurses, Marisa, that I haven't introduced to you before in the previous case. I'm very sorry, Marisa. She's from Medtronic. And here is Dr. Germán.
Mariano.
And who
Mariano.
is in the echo is Diego also? No, Mariano is our technician for anesthesia and our echocardiography who is changing. And all the team from technical issues working very hard here. I will present the case. If Claudio can show me the slides. Perfect. Let's go with the next. Yes. So she is a lady, again, 88 years old. He presented with the dyspnea in a functional class. No, the 2. No, I think we have a mistake here. Claudio, this is the patient number 2?
Sí, sí.
Okay. So they suffering from hypertension, dyslipidemia, hypothyroidism due to the Hashimoto's disease and chronic AF. There are such a significant similarities with the previous case that I say, wow, this is almost the same. Next. She is also on atrial fibrillation, as I told before, but she doesn't have any other conduction disturbances like the patient, the previous patient. Regarding the blood test, some renal failure in the borderline with the 50 of urea and creatinine 1.2 for a small lady. At the echo Doppler evaluation also done in another hospital, they found that a tricuspid valve heavily calcified with an area of 0.8 with gradient of high gradient, in this case 80 as a maximum and 50 at the medium with a Vmax of 4.5 with a normal left ventricular ejection fraction. She is not frail and she is not futile according to the heart team evaluation. Next. So following our routine practice, we did coronary angiography. The right is normal. It's a non-dominant or codominant right, and on the right side of the panel, you can observe the huge left coronary tree without significant lesions on the left main, on the LAD with some breaching in the middle segment of the LAD, very tortuous arteries, also the circ. Next. This is the left cranial and then the left caudal view where we cannot observe any significant lesion except this breach in the not occlusive breach in the middle segment of the LAD. Next. So we did the CT evaluation. Here the monitor is a little bit further. So the numbers are not that easy to see, but the mean diameter is 24. Is 22 by 25, something like this, with a perimeter of 78, with a coronary height of 13 and 15, with you can observe there a tricuspid valve. Next. So here you can observe once again the tricuspid valve, the measurements of the annulus diameter that I already mentioned. Next. This is the LVOT 23 by 27 with the area or perimeter, excuse me, of perimeter derived of 25 with the perimeter, total perimeter of 79. So the sinus sinotubular junction is also not that big, 27, 29, and 28. Next. And here we can observe significant calcification of the leaflets. The ascending aorta is 35 as a mean diameter. Next. Here we can observe the coronary height. For the left is 12, and for the right is 16. So it's something that we have to correct. The monitor is a little bit further than in the other room. Next. And here the aortic angulation is 46, which is not significant. The next. And here the iliac axis, which is the right femoral artery, is 5.8 by 6, a little bit more tortuous than the previous case, with some calcification at the bifurcation of the common iliac artery. Next. But anyway, we had decided to go by the right femoral. This is the left, where Dr. Fava have already done the puncture and also the venous access. Next, just in case we need a pacemaker. And this is the complete iliac arteries and also the abdominal aorta evaluation. Some calcium, but not that severe. Next. And here in the ancho CT, we observe also, I wouldn't say significant, but important calcification at the LVOT below the left coronary sinus. Dr. Fabian Salmo, who is in the echo, is going to check if the patient has pericardial effusion before starting the procedure while I continue with the presentation. Next. So according to the perimeter and according to the instruction for use of this valve, next, we are again in a little borderline, but we decided to go with the 29 valve. In this case, next, we decided to predilate. This is these are our measurements done by us here in the lab. Here you can observe 23 by 26 with a perimeter of 78 with an area of 473 with no significant angulation. The left main is at 11 and the right coronary artery is at 14. And here we have to write, okay, perfect. The cusp overlap view overlapping the right of the left sinus at the right oblique is 8. And the caudal inclination of 30. Is that 30, correct there? 8:30. Okay. Next. Here you can observe some prediction according to the BTC in this left ostium, which is not that high, but is not that low to be protected. The VC, or I mean the estimated BTC is 4.4. So I think it's still in the low risk for coronary obstruction. Next. So at the end, in a summary, is an old female, 88, with severe aortic stenosis and not futile, with the STS score for mortality not that high, like 3, and a mortality estimated at 20. And in the heart team and discussion, they agreed that this patient would benefit from transcatheter aortic valve implantation. Next. So we have prepared this case for today. Once again, we have decided to go by femoral access. We will do a gentle predilatation with only 18 millimeter balloon. Remember that we have some calcium at the LVOT, which is not that big. And we have planned to implant an Evolut 29 TAVI after this predilatation. Next. So let's go for a real life. So Carlos did the femoral access. We will try to do the crossover. We will spend much time in this case because the other one, we did it almost in a rush. So to be sure that we can complete one or if we can, the 2 cases once again in the slot time. Ahí nomás. We will do crossover. We try to do it. Which wire is? With a regular wire, but if you have problem, we can use the. We can use an hydrophilic with high support, but it was not necessary, fortunately. So Fabian, can you comment something about the echo? Let me check. You are. I think you are not hearing you. Anyway, comment to me and I will comment. Okay, according to Dr. Salmo, who is the chief of echocardiography here, is our eyes for doing mitral clip. He observed that it's a normal left ventricular ejection fraction with severe aortic stenosis with no significant reversion. So once again, the patient is obese. It's not that easy for the puncture. We are a little bit lower. Let's check here. No. So we can discuss about the use of echo. We use it sometime, but in some cases, or in most of the cases, we use the angio because we can observe a little bit better where is the bifurcation, some branches that we try to prevent to puncture. So under fluoro, I will stick here the skin. We check the position, which is too low. Let me go there. And Dr. Fay is gonna check. And let's go here. And we are in. So let's move the table down. And we will put the 018 wire by contralateral side. We will do some divulsion here. If I have the monitor in another position here, we will have to change. This is technical issues that yesterday Dr. Mehta was saying that at the beginning we might have some issues that we will try to correct during the experience. La guía 018, la heparina, is here. We complete the heparinization. We usually use for regular body index 10,000 units, and then we check the ACT. So we will cross with the 018 wire. We will check that we are going to the, we will try to go to the, here, the superficial, just in case we need support for exchanging the wire, the sheath, or in case we need a stent or whatever we need. Un poco para tu lado. Okay, thank you. We discussed in Sao Paulo last week that in some cases where you don't have contralateral access or any very specific case, you can protect from below. It's something that we use when we do IVAR or TIVAR, where we don't have contralateral access. Ponele agua adentro. So in this situation, we do angio from the 6 French sheath, and then under angio control, we puncture the superficial femoral artery, and we leave only the wire. If we have a problem, we can introduce a set, but if not, it's just a wire. And usually we don't have any kind of problem with this.
Entra tu password. Entra tu password.
So for our European colleagues that maybe are watching the case, and the colleagues who were doing the cases in the morning or last night, the ProLight we have here is different from yours. It's the old version. We still need the local agency approval to have the new ones, which is expected to be by the third or fourth quarter of this year. So this is still the weaker device. So that's why sometimes we have some problems. So we will need the ambulance wire First, the other proline.
No.
So the other situation could be patients with, I wouldn't say severe, because if you have severe, we try to find another solution like another access or the other femoral or
Si te aparece un
or the second option here is
a tu mail. No.
transaxillary or transsubclavian. I don't know if it is gonna work. Okay. So I mean, in this case is where we have, I would say, some classification that we still believe is safe to go transfemoral from this side. We use the old ProStar because the needles are a little bit stronger than this old version of the ProLine. Oh, I did the crossover just to show you that this was easy. Let me show you up more. Okay. So now we have put the 014 sheath. In this case, we are not going to use pacing wire from the right side, just we will pacing with the wire. And then if we have a problem, we can use this access to put the pacemaker very fast. So give me some water. For all who are watching the case, all the team is on silent, but usually they speak a lot, but not too much. They are funny guys. Dr. Germán, the patient is stable, everything okay? Yeah, perfect. So once again, pull it. Have you observed a lot of calcium, Fabian, in the valve? Okay. We in the at the floor we can observe probably more calcium than we expected. So let me try in our regular way. If not, we will change for an Amplatz catheter with the an Amplatz catheter with a straight wire. But anyway, we take some minutes. I think we are going a little bit too fast. Teneme el introductor. Que no se salga. If you point out to the middle where the valves open, usually you can cross with the pigtail. But if you cannot, you change. Like this. Okay. Oblicua derecha. Okay. So this is for the aorta, this is for the ventricle. Let me go.
Meanwhile, can I ask you something?
Yes, Dr. Gustavo is our moderator, Dr. Lev, and he has some question again.
If the patient has coronary artery disease, what would be your preference to treat it before, during, or after aortic valve replacement?
Very important question. Gustavo asked me about patients with concomitant coronary artery disease, how we manage here at Favaloro. first, we usually do angio to every single patient that is going to be evaluated. I think it's the pigtail. No? Let me check. So all patients have angio. If we have a significant coronary stenosis from the main vessels, we usually prefer to treat. But I know that this is not a general consensus. We had here in LATAM last week a very important meeting for structural heart disease in Sao Paulo, organized by SBHCI, the Brazilian Society, and Nico von Miguel discussed about the future trial that they are participating and evaluating patients treating before and after the TAVI. So the final answer for Dr. Gustavo is, I would say, we do something like this. We do angio, it was significant coronary stenosis, we treat before, but there is some clinical trials undergoing to check if it's better to do before or after the procedure in case it is necessary. What we have observed in our own practice is we are a little bit less aggressive regarding the coronary stenosis. For example, if we have a mild or moderate lesion in the LAD, probably some years ago, we decided to treat it, but now we decided to wait. At least this is a patient with some sign of ischemia. Functional evaluation would be useful, especially for intermediate lesions. You know that FFR is still not well studied in this subset of patients. This is something also which is ongoing in the trial. Nico von Megan presented in Sao Paulo. So probably, I think at the end of the year or the beginning of the next year, we have a better answer for your question, which is, I mean, a pending question or a pending answer, because nobody knows which is exactly better. But this is all the explanations we have. Once again, you have observed how I reshape the wire, the loop at the tip. I always transform in an extra small. So I don't care if it is mild or small or big. All my wires become small, and then I add the second bend. I also usually do this kind of shape for when we use the Landerquist wire, which is a stiff wire. Landerquist wire, we use it in very tortuous arteries and angulated aortas, and especially when we are using bigger valves like the 34 or something like this, where positioning is much more difficult than the 26, as you observed in the previous case, 24, especially if you don't have significant calcifications or a patient very fragile, like the patient, once again, we did yesterday with 10% ejection fraction, significant calcification. We don't have so many chances to repositioning. It's important to have a very stiff wire to have as much less movement as you can. So this is our suggestion about the Landerquist, or when we are using Landerquist. In this patient, we are going to pace in from the wire, so we have to put here a needle on the skin. We have the O18 balloon, el 18. Excuse me. What? Okay. Okay. Probably this patient would have tolerated perfectly at 20, but anyway, let's go gently. We are on live. We don't have any kind of surprises. So before crossing, I think Marisa have already prepared the valve. We can check it. Let's move here. Cover the face of the patient. Remember, not put any name, any face, nothing of the patient. That fulfill the HIPAA requirements. So Marisa. There you can observe perfectly both paddles. The valve is properly prepared. Almost as always. También la gasa grande. So please let to the other lab, if the patient is done and finished, Gustavo, to prepare the coronary case. Because if we finish too early, we will have a lot of minutes without doing anything. So
Okay.
probably we can incorporate today also a coronary case. So we are not trying to run too fast. This is our regular way of working. Everybody knows what they have to do it in the team. We don't have to speak too much. We only have to move as fast as we can and safe.
¿Qué? Ah, no, espera.
We usually can do 3 cases in 3 hours. If everything goes okay, for sure. Another potential question would be regarding valvuloplasty. When we use valvuloplasty before, it's only for patients who are descompensated inside the hospital. Here we are living in a very difficult economic situation. It's not something unknown for everybody. So it's almost impossible to put a TAVI in an immersion procedure and to have a high mortality rate. Okay. So that's why in these cases, we usually perform aortic valvuloplasty. If the patient recovers, then we can find the health coverage for the TAVI procedure. So now vamos a ir a 180, 180. Let's on. Vamos, balloon. No. Once again, let's go. Fast. Okay. Okay. Perfect. Stop. Spacing. Hold the groin. We have to reposition in the pigtail. Let's take this out before. Espera un poquito, Marisa, yo te digo. That's me. Oh, we haven't done the angio in the position. We have to go to the working position. Once again, talking, we have, be careful, move this. More. No, móvelo. Put here. Near the camera. There. Okay. No, more. There. More. So you are not interfering with the cameras. Okay, that's okay. So the position once again is 8 right, 30 caudal. Once again, it's not that comfortable. Let's check. Once again. Okay, I think the position is okay. So Carlos is gonna hold the groin. It's not gonna be that simple to change the other patient who was sleeping and to put the coronary case in less than half an hour in the other room to do 3 cases today. I think it's gonna be too much. So, okay. No yet, but if we finish too early, probably yes, Danny. Let's see how the situation is going here. So, Carlos, please. So once again, for those who are connecting now to the live transmission, so the port here, if you sum up a little bit, is oriented in the 3 o'clock position. So in this position, as I already mentioned, we can achieve a cusp alignment. I mean, that can facilitate the coronary access in the future, especially for young patients. Probably it's not the situation for these kind of patients with normal coronary arteries and 88 or 89. But it's important for younger patients when we are thinking about coronary artery disease and also reaccess in the case of TAVI in the follow-up. So not that much. I will stay in the middle segment of the pigtail. We'll pull the wire a little bit. Wait a minute. Let's reposition in the pigtail, which is torque around the valve. Now it's better. Let's zoom a little bit on zoom. It's much better. So let's test. Okay. We can start now. Dr. Fao is starting. I will prevent any movements. We'll try to be at 0 or 1 or 2, not that much. Test. Be prepared for 120. Pasito. 120. Okay, Carlos, dale. Test, nada más, no. No, we are too deep. Close it. Fast. This pressure is low there, Carlos. Let's go, let's go. Let's go. Dale, dale, dale. Dale, dale, dale. Okay, let's check and allow to recover de bajar el marcapasos. Vamos a verla en la izquierda. Okay, we will try to eliminate 60.
Ponen 30.
A ver. Let me check something.
Right.
There. Sí, sí, sí. Here's his her own rhythm. Let's a little bit cranial. There. Okay, there. There we don't have too much parallax. Let's inject. I think we are too deep. We will do an additional attempt in the right position. Let's go to the right again. If we can achieve a better position. So we will 120 de vuelta, 120. Carlos, lo más rápido posible, cerrando. Perfecto. Más. Dale ahora, dale. I like it. Let's bájalo. Apágalo. Okay. Test. Here we are at 2, not more. Let's go to the other side. A la izquierda. Little bit cranial. Por ahí. Vamos a inyectar. To be honest, I don't like it. I think it's gonna move. When we release the valve, it's gonna move down. Let's do one final attempt. Vamos a la derecha. Caudal. I don't like too much repositioning, but I think we have to be very careful in this patient. Close it and open it. Dale, cerrala. Cerra. Ahí, dale ahí. Marca paso. Dale. Okay, I think it's gonna be impossible to get something better. Test, baja el marcapaso. We are almost in the same position. One more. Cerralo, Carlos. Dale, abrilo ahí. Oh, no. Okay. Cerralo todo. Okay. Let's go once again.
¿Cómo?
Vamos, sí. Último intento. Dale. Dale, Carlito. Okay, well, I think we are in the same position. Bajar el marcapasos. I think we have too much angulation in the aorta, probably more than expected. Una más, Carlito. Cerrarlo una más. There, ahí, dale. Dale. No, dale, ahí. Dale todo. Ahí. Now we have a better position. Yes. No, sorry, boss. Because now we have a better alignment of the delivery system. Let's go to the left. Ahí no estaba. Volvé un cachito. Ahí. In shape. Yeah, much better. So we can retrieve the pigtail because test. The sinotubular junction is not that big. Dale, Carlito.
Oh.
Despacito, sí. Inyectar. Okay. Dale. Okay, perfect. Let's remove the pigtail. We have some issues there. Now the paddle is released. No, because it was stuck on the delivery. This is probably the depth of the valve. You can see where the wire is pushing the sinus. It's probably a 4 millimeters. But anyway, it looks a little bit higher. So now, first, we are sure that both pedal are released. Now we'll start to remove very slowly. We'll try to centralize the nose cone as much as I can. Like this, with this shape of my wire. And now I can push the wire, and now I am out. AP view. I think, I think it was important not to convince with this suboptimal position at the beginning, because we would have ended up very deep because the valve was in the inner curve of aorta, so it's gonna move to the outer curve of the aorta, and then it's gonna move dives into the LVOT. The diastolic is okay. The shape of the aortic curve seems okay. We will put the introducer here, and we will do echo before, and then we will do the ancho. Let's do the other way around. We have a very important echocardiographer here, so it has to work. Tell me what you see. Minimal. Okay. Are you hearing the echo, Danny? Okay. Sorry, excuse me. Could you change the configuration to see the echo there on the machine? Let's wait for a minute. ¿Dónde está Claudio Onan? Please, hurry up. Vamos rápido. ¿Qué hace? No, wait a minute because we are not seeing on the screen. We have to change the configuration. Sorry for this delay. ¿Dónde está Claudio? Claudio, configurame porque no está saliendo ya. Tenés que... Could you change the configuration to see the echo instead of the ancho? Danny, please.
Sitio que está más abajo.
A ver, Claudio, si vos lo cambiás. In the multi-images, Danny, you can find it because the echo, if we see here on the screen, you can see in your system. Okay. Oh, it's strange. What? Anyway, we will another issue to be checked. So let me comment. Okay. Could you rotate the monitor a little bit so maybe they can see with the camera number 1, little bit there. Danny, if you pointed out the monitor, maybe you can see there. From this camera that you're pointing me, you can point the monitor there and you can see the echo. To the right side, you have to point it. Yeah, you can zoom on the right corner, inferior corner. Perfect. We are almost a team. Yes. Yeah. So the peak gradient is 10, the mean is 4. Paravalvular leak is minimal. What about the depth of the valve in the long axis? Try to see. Perfect. Now we are watching the echo. Is that correct, Danny? Oh, great. Now we are a powerful team. Thank you so much. Please, Fabian, tell us what you see. What about the depth? Okay, according to echo, it's a little bit higher. It's 2 millimeters. Let me check with the ancho. So take, retrieve your hand, orientate the monitor again because he's watching the echo perfectly. Let me see. Saca la mano, Fabián, un segundo. Let's go to the multi-images again. Let's put the ancho. Okay. I think the depth is a little bit more. I think we can post dilate with the probably the 23, 24, no? Okay. Dame un balón de 23. Not that much because remember we have this sinotubular, I mean the LVOT calcification. According to Anjo, Fabian, the depth in the non-coronary cusp is probably 4, not 2. It's a little bit deeper than you are seeing there because I think because you have a lot of interference with the calcium because the non-coronary cusp is completely collapsed due to the leaflet and the calcium. That's why you cannot find exactly where is the area of the deepest part of the sinus. I think it's artificial. So we will prepare, please, let me check the dilution of the contrast. It should be very well diluted. Cover the face of the patient, okay. Not that much, it's not that big. Okay. Con 30 está bien. Está 30 en el... Because in a way it's semi-compliant, so it's okay. Probably in the oldest day, we will leave it like this, but we will try to fix it. But we are not going to be too much aggressive for the two reasons: the LVOT calcification to prevent any conduction disturbances that now is not, it hasn't appeared.
Okay.
Ok, vamos a 180. Espera que caiga.
Sí.
Vamos, rápido. I will push. Dale, dale, más. Okay,
Stop.
desinflar. I will push the balloon to prevent any movement of the valve. Dr. Carlos is gonna retrieve, holding the sheet. Okay, and then give me the pigtail. Sí, ya tenía. No, ya tenía. Okay. Could you check by echo again? So we can check if the echo is working properly. Let me put the pigtail. Wait a minute, Fabian. Put the pigtail. So perfect. Let's go. Perfect. Now we have echo on board. Let me inject some saline that you will see. Ceros. Okay, only mild. According to echo, the aortic regurgitation gradient was almost non-existent, 10 and 5. By here by Ancho is 0. The diastolic pressure is more than acceptable. It's 54, 400 as systolic, with a good Dicrot notch. Okay, let me retrieve the pigtail and do a final Ancho. And then we will close in the groin. Saca un segundito la mano, Fabián. Oh, no, seguí. I can wait. Dale. What about the circularity of the valve? It's completely circular. Perfect. Okay, okay. So no pericardial effusion, no very good ventricular function as it was before. Let me do an Ancho. Retrieve. Okay. Oh yeah, I'm going faster than the hospital, so patient is not gonna be ready to be live in 2 to 3 cases today. So okay, this is I will do the financial here. I think we have a mild play the Ancho. The mild paravalvular leak, but this is exactly in the place where we have the calcification of the LVOT. Here you can see very clearly the valve is I think it's in a very correct position. Cusp alignment is acceptable. Let's check in the working projection so we can see which is the real depth of the valve. Let's go to the 830. Tenías que tener grabado y te lleva directo. Trata de no romper las cámaras, por favor. Córrelo el monitor. Ahí está. Un poco más caudal. Ahí. Okay. Let's do Ancho here. Here.
1 millimeter.
Frízalo. Probably is given the right hand to Dr. Salmo. According to this image, one more. Let's stop more. Like here. Here, you can observe probably the valve is 2 or 3 at the most in the non-coronary cusp. So we cannot go higher. So the cusp alignment is okay. We can observe how free is the left ostium. Also the perfect, filling of the right coronary artery. So both pedal are oriented perfectly in the right view. In the left view, it should be the other way around. Are you okay? You think it's okay, Marisa? Okay. Marisa from Medtronic approved. So we will retrieve the catheter. No conduction disturbances so far. We will put the Lima catheter for crossover to check the closing, put an AP view. So this is a live case. So Dr. Salvo is ready to rush, but I had to tell him that he cannot rush because it's a live case. He has to wait. It's not going to be elegant if you are rushing out from the lab. Please stay with us. So this is a very obese patient. ¿Podemos revertir, Germán? Podemos hacer lo mismo que en el caso anterior. Vamos a pasar el mamario primero. Sí. Let's start with protamine. No, sacar la luz porque si no se quema la imagen. Ok. Un poco de dicroica, exacto. Regarding pre and post dilatation, we belong to a team with Eberhard Grube that we did the initial experience without pre-dilatation because we thought at the time that without pre-dilatation, probably we would decrease the stroke rate. But unfortunately, our theory was not that true. So now we are using pre-dilatation according to each patient. I would say that probably 60–70% of the cases we pre-dilate because we don't like to post-dilate, especially when we're using cusp overlap view and we implant the valves at a very high position to prevent conduction disturbances. So in this situation, sometimes post-dilatation is challenging, at least. Not risky, but challenging. No, mover de vuelta. Dame un poquito más de dicroica. Okay, now the light is a little bit better. So let's say you hold the groin and we can put the 6 French introducer set or this one. Okay, Carlito, voy a sacar todo sin cerrar. Germán, le diste la prota, ¿no? Comprimí bien que no sangre. So we are holding the groin. We are put the 6 in this obese patient. Sometimes we have difficult. So it's better to be sure that we are going to reach the. Let me go down a little bit. Still have important bleeding. Let's go with the other suture. That's why I'm not so fan of the one ProLife. Now I think we don't have significant bleeding outside the 6 French. So probably we are ready to retrieve the 6 French and the wire, or at least the 6 French and then the wire. We still have some bleeding. Prepare. Dame un balón de 8. So we still have some bleeding, so we will change the strategy. We will use the 8 millimeter balloon to inflate the contralateral to show why we are using the contralateral axis. Still protamine is entering into the patient, so muéstrame en la panza. Okay, so now we are pull the wire because now we don't have too much to do it. When we cannot cross here, is because the wire is stuck against the knots. So probably here we have to pull the wire out now like this, and then to re-enter like this, and then to go down. And this would be also a reason why it was bleeding. Bring me back a little bit. Now we can pull the thread a little bit more. Joaquin is going to inflate the balloon at 6-8 atmospheres. ¿Sí? Y quizás tenemos que revertir un poco más porque... okay. So we have the balloon here. It's too diluted. Deflate. No, ¿dónde es? Aquí, inyecta. So we will prepare a better dilution so we can see it much better. Dale. Okay. Saca el aire. Respira. Infla. Now it's okay. Now we turn on the clock. Okay. So now we have put order here. Now we have to make friends, to talk, and to wait for some minutes. At least 2 or 3. We will control the pressure because after protamine, sometimes we have hypotension. This patient is important to not have hypotension. But she is okay. I think we are almost done. We still are on our slot time. So, but anyway, in case you want to do anything else, of course, you are free. We are holding the groin. Let's discuss possibilities, just in case. For example, if we have like an oozing or little bit more than oozing here, release the. We don't have bleeding with the balloon. For example, we have a very significant bleeding. We can advance the balloon, and then we can exchange the wire with an 035 wire, like an Amplatz or something like this. We pull everything out. We change the contralateral set, and we can put a contralateral sheath, 6 or 7 French, and through this sheath, we can advance a balloon, inflate again, and then if we cannot reach the complete sealing of the femoral artery, we can deploy a balloon or self-expandable stents. How we decide between one of the other, patients to patients, and also availability. In these very old patients who are not going to be sportive or obese, that the possibility of compress this stent, you can use it perfectly, a balloon expandable stent. We haven't had any kind of problem with these stents in these patients. But if it is a very thin patient with a highly superficial common femoral artery, probably it's going to be better to put a self-expandable stent. When surgery, well, surgery could be an option, but although this is the house of the surgeons, they are always looking after us. We can, ask for a surgical repair if we have destroyed the vessel and we don't have access, or if the patient is too thin. But in this kind of obese patients, if you do surgical repair, the possibility of complication is high regarding infections, regarding lymphocele, and any other complications. We have one historical case who stayed in the hospital for 3 months after we have some bleeding like this or a little bit more at the beginning of our experience, and we decided to repair by surgical, cut down. So that's why now it's better to put a cover stent. The patient is going to go tomorrow, everything okay. The patient is not staying in the hospital, which is always a source of complications. So I have spoken for more than 3 minutes, so it's time to deflate the balloon and check it again. Well, anyway, we can go to the room and show the shots that we are starting. So we don't have any bleeding there. Are we connected? Now I feel much, much better. This is the kind of the patient that you have to be very sure that you don't have a deep bleeding because she is very heavily obese. So when you realize when he sees you, whatever, probably the bleeding is too much. It's not that good. So it's better to be sure. Yeah. And now we can close the groin. Tenemos la seda ahí.
Sí.
Once again, for those who are connected recently, we are prepared the groin like in the surgical fashion. We use a sterile drape just to keep everything out of contact with the skin to prevent any kind of infection. We leave one not there. Carlos is gonna hold the groin still for some minutes while we are finishing, and we are going to use an Angio-Seal 8.
Angio-Seal
8. Leave it. Sí. Once again, as we did in the other case, mostrame acá, cuidado la mano, Carlos. We are pulling the wire first to be sure we are not damaged the carrefour, and now it's out. And now we are going to close this groin. We have too much things here. I don't like it. Give me the Angio-Seal. And then we push the groin to close the femoral access. I think it's not necessary to leave. I will ask Germán if he need el acceso lo necesita. No. So we will retrieve the venous access by holding the groin as we did in the past as a good fellow. If you ask me which is my more important expertise, to hold the groin from the era of the aortic balloon valvuloplasty with 10, 12 French sheath, and we have to hold the groin for hours. Okay, I will try to go to the other room just if we have the patient at least scrub. The patient al menos está tapado para acceso femoral. To do an ancho. Because this is real life. We have to show what we are doing. So we are finished. We can hold here the groin for some minutes. He is going to retrieve this sheath, hold the groin, and they are checking if the patient is scrubbed. If it is covered, I can go to the other room. And at least I can to present what I am going to do for the next case we have here. Is a left main. Okay, I'm going to the other room just in 1 minute, and we can do at least one ancho to fulfill this 15 minutes. Like a TV show, we have to try to complete, so I'm not disturbing our colleagues that probably are not ready to live 15 minutes in advance. I will to change the microphone. Let me go to the other room.
Espera. Estoy en lo cortaron.